Good afternoon, everyone. It's a great pleasure to be here today as advisor of Iorizzo, who will be defending his dissertation, dosimetry and real-time monitoring of phototherapy. And the committee members are Erno Sergio, who is director of medical physics program, Cecil Joseph, who is expert in optical and terahertz spectroscopy and imaging, and Walfred Franco, who is an expert on optical Monte Carlo modeling and biomedical optics. So I will start as customary in our lab by introducing Tyler and outlining his many achievements, because what is included in his in his thesis is just a small part of what he has accomplished during his stay in the lab. He joined Advanced Biophotonics Lab in 2019. And since then, he has published 5 peer-reviewed publications. 2 of those publications are in scientific reports, in Nature Scientific Reports. 3 of the publications are as first author, and we also filed 1 patent. He has won multiple prizes, as well as he has been best overall graduate student 2 years ago. One award that he won was very prestigious Edmund Optics Award on optical polarization imaging. And he has more than 15 conference presentations, at least 2 of which I didn't count, at least 2 of which were invited. So please welcome Tyler. And remember, that's not all that he has been doing. He has done much more than he presents.
Thank you. Thank you. Let me put this in presenter mode. Okay. So I'd like to thank my committee for being able to make it today so that I could give this presentation. And today I'll be presenting my PhD dissertation on the dosimetry and real-time monitoring of phototherapy. So here is an outline of my presentation, where first I will give a brief introduction specifically to phototherapy procedures, dosimetry in phototherapy, and treatment monitoring in phototherapy.
I apologize. Can you move the bar so that people can see the time?
There we go.
Yeah.
Okay. After the introduction, I will then go over 3 publications of our group. The first one being the validation of a Monte Carlo modeling-based dosimetry of extraoral photobiomodulation. Then Monte Carlo-based dosimetry of extraoral photobiomodulation for prevention of oral mucositis. And then an optical method for monitoring changes in tissue temperature using near reflection. I will then provide overall conclusions and finally provide recommendations for future studies. There. Phototherapy refers to any medical procedure which utilizes optics and light to treat medical conditions. They can treat a wide variety of conditions using a variety of different parameters and illumination methods. And to highlight this, I will provide 3 example phototherapy modalities: photothermal therapy, laser surgery, and photobiomodulation therapy. Photothermal therapy, or PTT, is a procedure that uses light to heat and coagulate tissue. So this modality of phototherapy illuminates the target tissue and via light absorption heats or cooks the target tissue to a specific temperature, usually to the end goal of coagulating the tissue and therefore killing the target area. Examples of photothermal therapy is laser-induced interstitial thermotherapy of brain cancers, which we can see two MRI images here, where the first image here is pre-treatment, where the target site is highlighted in this white box. That's where the tumor is. And in the right picture, this is post-treatment, and you can see based on the MRI image that the treatment coagulated the tissue and treatment was provided. Laser surgery employs lasers to ablate and remove tissue. Examples of laser surgeries are LASIK, prostate tumor removal, and kidney stone lithotripsy. Similar to a photothermal therapy, the target tissue is illuminated by the light source, but the end goal is to ablate the tissue and therefore remove it from the target site. And here we have photobiomodulation therapy, which utilizes light to promote wound healing and analgesic effects in the target area. This can be used to prevent side effects of radiation and chemotherapy. It also has other implementations in other fields to provide tissue repair techniques. Treatment monitoring during phototherapy procedures. Absorption of light during these procedures will lead to an increase in tissue temperature. Having a method to monitor tissue changes in tissue temperature is needed to ensure that the efficacious dose is delivered and to minimize any undesired side effects. Current methods for measuring tissue temperature during phototherapy are either invasive or are time-consuming, and therefore you can't provide real-time feedback for temperature. So the first paper that I will review here is a validation of a Monte Carlo modeling for dosimetry of extraoral photobiomodulation. In this study, what we wanted to do is to validate the use of a Monte Carlo program for simulating transmitted light through soft tissue, and specifically here for the oral cavity. So the study design for this project, we had 4 volunteers with varying skin types. We acquired T1 weighted MRI images of each of the volunteers' heads and the thicknesses of the skin, fat, and muscle layers were determined from the acquired images. Morphology from the MRI and optical properties from the literature were used in the Monte Carlo simulations to determine the light transmission through the cheek. And in vivo light transmission were performed to compare the Monte Carlo results. So let's review the processes that will occur as light is transmitted through turbid medium. So here I have a diagram, and above the tissue here shown in gray, we have the incident beam. The incident beam, part of the light will directly reflect off the tissue, whereas the remainder of the light will transmit through. As the light proceeds to go through the tissue, we will have a variety of attenuation processes occurring. Specifically, we will have absorption and scattering. Absorption, we quantify with the absorption coefficient, which I have labeled here as mu A, which is measured in terms of inverse millimeters. It's the probability of a photon being absorbed per unit thickness of the tissue. Similarly, scattering is the probability of a photon scattering while in the turbid media, and it is also in units of inverse millimeters. And then we have the scattering phase function, which will describe the probability of photons scattering at specific angles. It's the probability function describing how scattered photons will distribute angularly. And we have the anisotropy factor, which is the average cosine of the scattering angle. Light will undergo these processes as it transmits through the turbid media. And we will have a portion of the light being absorbed by the tissue, parts of the light transmitting through the tissue, and then we will have portions of the light noted here, diffusely reflected light. It will travel through the media, but travel back towards where the illumination source is. In the Monte Carlo technique, we will start by simulating a photon at the surface of the model tissue, and we will place a weight on that photon. And here I have the initial weight of the photon being denoted as W0. And what I present here is the basic Monte Carlo algorithm used in this study. So we first use the source distribution to generate a random position and direction of the simulated photon. And then we will generate a path length in which that photon will travel. As the photon travels that path length, the Monte Carlo program will check for any sort of special events, such as reflection, refraction, or the photon exiting the medium. If any of those special events occurs, we terminate the photon and increment that special event counter by 1, and we will restart the Monte Carlo simulation back at the source. If none of those special events occurs, we move the photon to the new position and we calculate the new photon weight. The new photon weight here is listed as WK. WK minus 1 is the previous weight of the photon, and A of RK, that is the albedo of the photon in that medium, at that location, R sub K. We now check the weighting, the new weighting of the photon. If if the new weight of the photon is less than the minimal acceptable photon weight, we will then generate a new random number. If that random number is greater than the predetermined survival probability, we terminate the photon and then we then simulate a new photon from the source. If the new random number is less than the survival probability, we will then increase the minimal acceptable photon weight and then generate a new scattering direction from there. And the scattering direction here, the angle theta, is determined by the Haney-Greenstein scattering phase function. If the new weighting of the photon is greater than the minimal acceptable photon weight, we can skip this new generation of random numbers and check if the simulation accuracy has been achieved. If the simulation accuracy has been achieved, we can stop the simulation and analyze the results. If not, then we generate the scattering angles and we generate new path lengths, and that process continues. So that is the Monte Carlo technique that we wanted to validate in this study. We used axial T1 weighted MRI images as a model. Specifically, we used the Stenson's ducts as a landmark to ensure that we were imaging the same location among the 4 volunteers. And a line shown here in red was drawn, and the thickness of the skin, fat, and buccaneer muscle layers were determined. And here is a summary of the subject summary for this study. So we had equal representations of gender. We had 2 male, 2 female. Ages ranged between 25 and 57. Skin types ranged from skin type 1 to skin type 6. And we had quite a variation in tissue layers. Skin varied between 1 and 2 millimeters, fat between 0 and 3, and muscle between 3 and 7. And we also used the optical properties from the literature in this Monte Carlo modeling. So specifically, we have the absorption coefficients and the reduced scattering coefficients of the skin, fat, and muscle layers. And all of these are specifically for 850 nanometers, which was the wavelength we were interested in using. These optical properties were assigned to each voxel. The thickness of the structures were determined from the MRI images, and a layer model was used in the Monte Carlo simulations. So in the simulation, the tissue model looked similar to this, where they formed layers, the different tissue types formed layers on top of each other. We had skin, then fat, and then muscle as you traveled deeper and deeper. This is what we used as a light source. This is already being used for photobiomodulation therapy as a light source. So we both use this for simulations and for in vivo transmission measurements, which the device can be shown here on the right. So in vivo transmission measurements were performed. The power density inside the cheek at the intraoral mucosa and the thickness of the cheek were recorded under a controlled pressure of 18 grams per centimeter squared. For each subject, we performed at least 8 independent measurements. And we measured the effective attenuation coefficient using Beer's law. Afterwards, determining the average transmission from this and comparing that average transmission to the Monte Carlo results. So here are the results for subject number 1. The graphs here show the Monte Carlo results, where on the left we have fluence rate in units of watts per squared centimeter, and on the right we have absorbed power in watts per cubic centimeter. The z-axis is tissue depth. The r-axis is the lateral radius from the center of the illumination source. And the vertical axis here is the fluence rate and absorbed power for their graphs, respectively. These axes are in logarithmic scale. So as you can see, the fluence rate in the logarithmic scale decreases almost linearly, which means that the fluence rate is decreasing exponentially as you go deeper and deeper into the cheek tissue. My apologies. I should also note, shown here in this transparent gray are the border lines between tissue layers. So everything before the first gray wall here, that is the fluence rate within the skin layer. Then we have the fat layer, and then we have the muscle layer. In absorbed power, we also see a exponential decrease. However, we see huge discontinuities at the tissue boundary layers. So from skin to fat tissue layers, the absorbed power dramatically decreases, and that is due to the lower absorption coefficient within the fat layer as compared to the skin layer. And vice versa, as going from fat to muscle, there is a dramatic increase in absorbed power due to the higher absorption coefficient in the muscle layer as compared to fat. And below here in the table, the transmission here is the transmission measurement determined from the in vivo measurements. So we have the results here for subject number 1, subject number 2, 3, and 4. And we can see that trends in terms of fluence and absorbed power distribution from the Monte Carlo results are similar in terms of their exponential decrease and where the discontinuities in absorbed power occur. The results from this study are summarized here, where we have the measured transmission for each of the subjects highlighted in blue here. The simulated transmission determined from the Monte Carlo simulations highlighted in green here, and the percent difference. And as you can see, in 2 of the subjects, we only had a 1% difference between simulated and measured transmission. subject number 3 had 11% and subject number 1 had 12%. So of the subjects used in this study, we found that the simulation results differed by at most by 12% compared to the measured transmission. So conclusions for this study, experimental and simulation results were in good agreement for all 4 subjects. The differences between the mean values of the measured and the respective transmission measurements determined from the simulations were within 12%. And therefore, Monte Carlo modeling is a robust and reliable method for light dosimetry. So now that we've reviewed the validation of using Monte Carlo for determining dosimetry through turbid media, I will now proceed to discuss our study on Monte Carlo-based dosimetry of extraoral photobiomodulation for the prevention of oral mucositis. Oral mucositis is a toxicity of intensive cancer therapies, usually due to head and neck radiation therapy, high-dose chemotherapy, and hematopoietic cell transplantation. Oral mucositis is characterized by ulcerations in the oral pharyngeal and esophageal mucosa, and it usually leads to worsened clinical outcomes, severe mouth and throat pain, requiring opioids, inability to eat and drink, decreased quality of life, increased length of hospital stay, and the potential of bacteremia or infection. PBMT, or photobiomodulation, can be used in preventing the formation of oral mucositis. The advantages of using extraoral PBMT as opposed to intraoral would include simpler application and ability to treat the oral cavity and esophagus. LED arrays allow for large surfaces to be treated within a single exposure. There's an ease of delivery and comfortable for the patient during the treatment, and ideal for pediatrics, easy to be administered, it's safe and it's well tolerated. But the dosimetry study is needed to determine the optimal parameters to deliver the same dose as if you were to use intraoral PBMT. So in this study, we 18 pediatric patients participated, in which archival T1 weighted MRI images of the volunteers' heads were acquired. Thicknesses of each tissue layer were measured from the MRI images, and the morphology from the MRI and optical properties from the literature were used as models in the Monte Carlo simulations. So here is a summary of the pediatric patients used in this study. We have separated the patients into 3 groups with respect to their ages. Ages range between 5 years of age and 20 years of age. And we had an equal representation of male and female patients. From each of these patients, we specifically looked at 4 potential treatment sites for extraoral PBMT. The cheek, lip, specifically the lip anterior midline, right underneath the mandible angle, or what I may refer to as chin for the rest of this presentation, and neck, specifically the anterior midline of the neck. And for all of these patients, we looked at all 4 of these potential treatment sites and determined and measured the tissue layers in each of those. For modeling, we employed the Monte Carlo simulation that we used in the previous study that I covered in this presentation. And we aimed to find the optimal treatment parameters such that an efficacious dose of about 2 joules per centimeter squared was delivered to the oral mucosa, that treatment time could be within 15 minutes, and that the power densities on the skin were within the ANSI standards, so that no thermal effects would occur during treatment. Here are the optical properties used in these simulations, where we have the optical properties of type 1 and type 6 skin, subdermal fat, muscle, and cartilage. And we also had the blood optical properties, but no major blood vessels were found in any of the 4 treatment sites I will be discussing here. What I'm presenting here are the simulation results for subject number 17 at the cheek treatment site. And I'm presenting these results specifically because for the cheek treatment site, subject 17 had the thinnest total tissue thickness. So the combination of skin, fat, and muscle found for subject number 17 was the thinnest out of all 20 of all 18, I'm sorry, subjects in this study. During simulations, we varied the melanin concentration within the skin layer. So without melanin, the results are shown on the graph on the left, and with maximum melanin concentration are shown on the right. And in the table below, we can see that the fluence rate, which reaches the mucosal tissue, differs between 2.5 times 10 to the negative 3 watts per centimeter squared for no melanin within the skin layer, and 2.05 times 10 to the negative 3 watts per centimeter squared with melanin. And here are the absorbed powers for subject 17 at the cheek site, where we found that the absorbed power at the skin layer differed between 0.033 watts per cubic centimeter for no melanin, and 0.05 watts per cubic centimeter with melanin. That being said, when we compare subjects, and here I'm comparing subject 17 and subjects 21, as I have labeled here, when we compare subjects that had the thinnest total tissue thickness to those with the thickest total tissue thickness, we see that the variation in fluence rates at the mucosal tissue vary far greater than they do due to the concentration of melanin within the skin layer. So as we can see in the table here, subject 17, who had the thinnest, in this case is for the cheek, it had the thinnest cheek, total cheek thickness, had a fluence rate of 2.5 times 10 to the negative 3 watts per cubic per squared centimeter at the mucosa tissue. Whereas subject number 21, who had the thickest cheek, had a fluence rate of 1 times 10 to the negative 4. So it is more than an order of magnitude difference just due to the fact of the variation in tissue thicknesses. Those trends were found for all 4 of the treatment sites found, where the greatest variation in transmission and therefore dose delivered to the mucosal layer was due to the total thickness of the treatment site. And to establish a universal treatment protocol to account for all of these anatomical differences, we decided to go with a median treatment time approach. So what I'm presenting here in the left column is the median dose delivered within 1 minute of treatment. Whereas in the right column, we have the median treatment time in order to deliver the efficacious dose of 2 joules per squared centimeter. And if we compare treatment times, all of the treatment times are within 15 minutes. The cheek had the longest treatment time of about 11 minutes, whereas the lip, and again, specifically the lip midline, had the shortest treatment time of being even within 1 minute. So from these results, we were able to establish a universal treatment protocol using the Monte Carlo simulations that we validated, ideally to account for these differences in anatomy across all the patients. You would make a personalized treatment. You could run Monte Carlo simulations for each patient prior to treatment. And we've verified that you can do that. However, we have also provided the median treatment times in order to provide a universal treatment protocol. Concentrations of melanin requires about a 20 to 30% adjustment in treatment time. However, as I've discussed, the melanin concentration within the skin layer is not as high of a contributor to the variation in treatment doses as compared to the thickness of the treatment site. Extraoral PBMT has the potential to improve oral mucositis management due to pediatric cancer treatments. And lastly, the last study that I wanted to review today with you is an optical method for monitoring changes in tissue temperature using near or near infrared reflection. Accurate temperature monitoring is required for proper dosimetry of light and other treatments as well that may induce desired or unwanted treatment increase. So in treatments such as photothermal therapy, an increase in temperature is desired, whereas in photobiomodulation therapy, we want to avoid an increase in temperature being that tissue repair is the end goal. And having an accurate method to monitor tissue temperature is needed in either case. Current methods for monitoring tissue temperature, such as thermocouples and fiber optic sensors, are invasive. And other such modalities for monitoring tissue temperature require long acquisition times, so real-time monitoring is not possible. In a previous study, we found reproducible and statistically significant changes in the tissue optical properties of in vivo tissue during heating. And specifically what I'm showing here in this graph here is the blue shift of a water absorption peak in the absorption spectrum of in vivo skin. And as the tissue temperature increases, the peak wavelength of absorption shifts to shorter and shorter values. The tissue temperature induced changes of in vivo skin optical properties may be used to improve dosimetry in phototherapy procedures. Monitoring light reflectance in the vicinity of these water absorption bands may provide real-time feedback for therapy procedures that involve tissue healing. So in this study, we utilized freshly excised discarded skin samples acquired from surgeries at the Massachusetts General Hospital Dermatology Department, where skin samples were heated from room temperature of about 20 degrees Celsius to temperatures of 36, 45, and 60 degrees Celsius. While held at these temperatures, the reflectance spectra in the spectral range of 900 and 1650 nanometers were acquired. Minimal locations within the reflectance spectra were determined. And a student's t-test was performed to analyze differences between the minimal locations in the reflectance spectra acquired at different tissue temperatures. So here is a picture and a schematic of the laboratory setup used, where what I have labeled as 1 here is the halogen light source. Light was then transported using a illuminating fiber optic and was focused onto the sample in a 4 millimeter spot size. The skin sample laid on top of this aluminum plate, where the aluminum plate was heated and temperature controlled using the power supply and temperature control unit showed as unit 7 here. Remitted light from the skin samples were collected by another fiber optic labeled as unit number 6. And the collected light was analyzed using a grading spectrometer. While measurements were performed, the temperature of the skin samples were also monitored using a thermal camera. And measurements were performed for 3 collection fiber optic angles. So the fiber optic angle, as you can see in the picture here, is oriented at an angle, and I have labeled that angle in the schematic here. We've acquired data at 3 angles, at 10 degrees, 30 degrees, 20 degrees, and 30 degrees with respect to the perpendicular normal of the skin sample. Here is an example of reflectance spectra between 1350 and 1550 nanometers. where we can see the reflectance minima or minimum due to the absorption peak occurring at this same wavelength. In blue is the reflectance spectra acquired at room temperature. Green is 36, gray is 45, and yellow is 60 degrees Celsius. And you can see, as I have labeled here in red, and I have also labeled the exact value, the minima location, the position of the exact minimum blue shifts with increasing temperature. In this specific case, it starts at 1448 nanometers at room temperature and eventually shifts to 1438 nanometers at 60 degrees Celsius. What I'm presenting here are the blue shifts for the 3 minima found in the reflectance spectra, specifically in the 10-degree angle configuration. The 3 minima in which we found were in the vicinity of 980 nanometers, 1200 nanometers, and 1450 nanometers. In the vicinity of 980, what I'm showing here is the mean, the average location, and the bars correspond to standard errors. At room temperature, the mean location was 977 nanometers, 1199 nanometers, and 1450 nanometers. As tissue temperature increased and eventually reached 60 degrees Celsius, we can see that the mean wavelength location of these minima shifted to 972 nanometers, 1194 nanometers, and 1436 nanometers. It can be readily appreciated from these graphs that the 1450 nanometer peak exhibited the highest blue shift. And my screen is turning red. Oh, I'm sorry. Speaking of color shifts. There we go. I apologize for that. Okay. In the first case here, we have a blue shift of 5 nanometers. In the top right case, we have a shift of 5 nanometers. And in the bottom case here, we have a shift of 14 nanometers. So we can appreciate that at 1450 nanometers, the highest blue shifts are observed, and wavelengths, longer wavelengths in the near infrared should be utilized for monitoring these changes in temperature. And here I have a summary of the blue shifts specifically for the 1450 nanometer minima or 1450 nanometer peak found at each of the fiber optic angles investigated here. I have the blue shift as tissue temperatures increased from 20 to 45, shown on the left, and the blue shifts as tissue temperatures increased from 20 to 60, shown on the right. Blue is for 30-degree fiber optic angle. green is 20 degrees, and red is 10. And as you can see, specifically for the blue shift from 20 to 45 degrees Celsius, that the 10-degree fiber optic angle provided the highest blue shift at this wavelength compared to the other fiber optic angles. And as tissue temperatures increased from 20 to 60 degrees Celsius, the 20-degree fiber optic angle provided the highest blue shift. In both of these cases, the 10 and 20-degree fiber optic angle configuration only differed by 1 nanometer. However, they both do provide a higher measurement compared to the 30-degree fiber optic angle, which suggests that for measurements, a smaller angle is preferred and will provide a higher blue shift measure. Conclusions. Temperature-induced blue shifts of water absorption peaks were measured using diffusely reflected light as tissues were heated from room temperature. Blue shifts were most noticeable at 1450 nanometers, where we found shifts of 14 plus or minus 1 at 10-degree angle, 15 plus or minus 1 nanometer at 20-degree angle, and 12 plus or minus 1 nanometer with the 30-degree angle. The results of this study indicate the feasibility of providing temperature feedback using diffuse reflectance measurements. So overall conclusions for the 3 studies that I have presented here today. We have validated the accuracy of Monte Carlo simulations in predicting light transmittance through soft tissue. We have established a universal treatment protocol for extraoral PBMT of oral mucositis, and we've developed a method for real-time monitoring of phototherapy procedures by analyzing temperature-dependent shifts in the reflectance signal. Recommendations for future studies, specifically for the Monte Carlo-based dosimetry of extraoral photobiomodulation therapy. Clinical trials are underway to confirm the efficacy of this universal treatment protocol that we've established in the study. And furthermore, we could utilize the methods used, i.e. the Monte Carlo simulations, the archival MRI images, and the optical properties from the literature to establish dosimetric plans for other phototherapy procedures. With regards to the optical method for monitoring tissue temperatures, we would like to implement this technology and test it during phototherapy treatment to see if tissue temperature can indeed be monitored while the procedure is being performed. We would like to test an implementation of this technology which utilizes multiple fiber optic probes, such that if we place these sensors at different distances from the source, we could potentially measure tissue temperatures at varying tissue depths. And we would also like to analyze the differences in measurements made using healthy tissue versus using cancerous tissue. I would like to thank everybody who has worked on any of these projects. Without anyone here, none of these projects would have turned out nearly as well as they have. Thank you.
So Tyler, after long deliberations, we all agreed that you did a great job presenting, but also feel that you've done much more than you presented, and that you could have added more publications to the thesis, but we decided not to make you do that. And we all agreed that you deserve PhD degree. So now you are a doctor of philosophy.
Thank you. Thank you.